And when you're looking at using this in your clinical practice, do you think you'll mostly use the combination approach or monotherapy or just try and tailor it to the patient?
So, I mean, I think everything needs to be tailored to the patient, right? I mean, that's always the right answer. So it's interesting because, obviously been very involved in this. So since the data have come out, I've asked a lot of people, what percent of your patients, taking in the age of your patients, sexual activity, when you lay both out as options, what percent of your patients do you think are going to choose monotherapy? And I've heard numbers from, 50, 60, 70% to 0%. I've heard everything in between. But if I had to have to say, what's the mode, the median, the most common number I'm hearing, it's probably around 30%. And I would say it's probably similar. I think particularly for the younger patients, or quality of life, particularly sexual activity quality of life, predominates, then I think monotherapy is a great option. If really the goal is to maximize aggressiveness of therapy and sexual activity is just not that important, then the answer is clearly the combination therapy. So I think it's going to be tailored to the patient. I think it's going to be a subset that will go on monotherapy. I think it's probably not the majority.
Right. And how do you see this data? The hard part in prostate cancer, the landscape changes so fast. And so you design a trial and the landscape sort of moves underneath you. How do you see this data being applied for patients who are getting PSMA imaging, given that we define these as biochemical recurrence with no metastatic disease on conventional imaging? How do we use these data in the patient who gets that scan, whether the PSMA is negative or whether it's positive?
Yeah, no, it's a great question. And so I think what EMBARK tells us, I'm going to come back and answer your question in a second. I think what EMBARK tells us is how to do systemic therapy when you're ready to do systemic therapy. It doesn't tell us when. So with PSMA imaging, you basically have three possible outcomes. One is it shows nothing. These are high-risk biochemical recurrence. PSA is going up very rapidly. I'm probably ready to start systemic therapy soon. And EMBARK tells me how to do that when that time is right. So the PSMA is positive either with oligomets or widespread mets. If it's widespread mets, I definitely want to start systemic therapy. I'm not going to do metastasis-directed therapy. And EMBARK tells me how to do it. So let's take the one scenario that throws a little bit of a monkey wrench and that's oligometastatic disease on a PSMA. And so my options are either metastasis, nothing, right? But assuming you did this because you want to do metastasis-directed therapy. So I'm going to do metastasis-directed therapy. Do I need to add systemic therapy? Should it be intensified ADT? We don't have that answer. There's no randomized trials of metastasis-directed therapy plus minus other things. So we don't know. I would argue that there's probably, it's a belief, it's not necessarily based upon the EMBARK data, that there's probably a benefit to aggressive ADT. But let's just say you want to follow the STOMP and the oral regimen, you want to defer systemic therapy, and that's the goal of metastasis-directed therapy. It's fine. Do metastasis-directed therapy. With these short doubling times, this is not your guy that took 10 years to develop a PSA 0.2 and has one small spot. I mean, these are really, median PSA doubling time was 5 months in EMBARK. These are the high-risk doubling times. You're going to do your metastasis-directed therapy. You're going to re-image them in 3-6 months, and then it's going to be widespread disease. I mean, you're probably not going to get those cures, and then now we're in an EMBARK situation. And again, I think if you want to do systemic therapy for that metastasis-directed therapy, I think that's where EMBARK is nice, because again, it's 36 weeks. It's not committing to something lifelong. It's 36 weeks. Let's throw the kitchen sink, pedal to the metal. Let's be aggressive. Let's do metastasis-directed therapy, intensified ADT, and then reevaluate. And if we got a good response, we stop and see. So I think it can play in very, very well in a PSMA world, but you're right. When we started the study, PSMA was not widely available.
I think that shows a bit of an evolution of prostate cancer treatment. For a long time, we've been, once you start it, you're committed for life, whereas you look at other diseases and we layer in therapies, right? One at a time. We're not using combination approach. And you look at other places, the hematologic oncologists in particular, right, may throw 4 or 5 agents at someone for a short period of time and then give them big drug holidays. And I think these data, when you put together both the metastasis-directed therapy and the notion in EMBARK of, short-term intense therapy followed by drug holidays, we're really moving potentially in that direction of, hitting hard and then giving patients a break.
And I think that makes sense. I mean, what's interesting to me is when you look at the control arm of EMBARK and metastasis-free survival, so metastasis or death at 8 years is not even median in the control arm. So ADT alone is good in this space. It's just enzalutamide is better, but it's a long natural history. Even in these high-risk guys, it's a long natural history. So to commit them to something lifelong is a hard sell. But 8, 9 months of aggressive therapy, let's knock it down, and then we can buy a couple years off therapy. That's not so bad. And we're looking at, there's actually a subset of men, not the majority for sure. I mean, it's a small single-digit %, but once they've gone off therapy, 5 years later are still off therapy, even in the monotherapy arm, where we know they have normal testosterone levels. So these are really potent drugs that we can get really deep tumor responses. In some patients can be super long off therapy cycles.
You kind of alluded to with the, favorable natural history. One of my last questions, which is, if you look at the AUA guidelines right now, pre-EMBARK, they actually told us not to do anything. Like the recommendation was to not give ADT and just wait for radiographic evidence of disease. So how did the control arm get decided on for this study? And what's your thoughts on, observation alone in this patient population, acknowledging that they're high risk?
Yeah, and so I mean, I think it's tough to compare hormonal therapy, intensified hormonal therapy, with a control arm that's no therapy. Because then, when you develop METs, are they really castration-resistant METs? Are they hormone-sensitive METs? You're kind of mixing apples and oranges. So I think you need some hormonal control arm. So I think we chose the right control. I certainly, appreciate the AUA guidelines, but if you look at real-world data, that's not what's happening. It's very uncommon that a patient will actually sit and wait until they have metastatic disease to start therapy. That's just not what's happening in the real world. And I think, to your final thought there is these are high-risk patients. They are not your average BCR patients. When you go back to the old Hopkins data, this is about a third to 40% of patients. So these are the bad actors. And, we looked at some real world data that we presented as a podium at the AUA. In this cohort of EMBARK-like patients in the real world, the median time to starting ADT, systemic therapy, was less than 1 year after they met the EMBARK criteria. They are not waiting for METs in the real world. And so we tried to model our study, not necessarily after the current guidelines, but actually what's being done in the real world, which is start systemic therapy early. And for these high risk, not all BCRs, I think for low risk BCR, your doubling time is 2 years. Yes, you probably should wait for metastasis. Again, PSMA, metastasis directed therapy aside. But for these high risk patients, they need something, and they need aggressive intensified therapy with enzalutamide plus minus ADT. We now know that.